Hello, good evening once again. Today I'm going to discuss about the dysmotility disorders of esophagus. There are quite a few dysmotility disorders that we come across in the hospital practice. We can classify them into primary and secondary group. Among the primary group, we have the achalasia and diffuse esophageal spasm. Among the secondary group, we have autoimmune rheumatic disorders, commonly the scleroderma. Then we have Chagas disease, diabetes mellitus, amyloid, intestinal pseudo-obstruction, and lastly but not the least, the myasthenia gravis. What is an achalasia and how it presents? Achalasia usually presents as a difficulty of swallowing and retrosternal chest pain. It is characterized by a high lower esophageal sphincter pressure and failure of the relaxation of the sphincter. There is also poor peristalsis throughout the esophagus. Now, what is the pathogenesis of achalasia? The pathogenesis of achalasia cardia is still unknown, but quite a few causes have been denoted. They are: number one is inheritance, number two is neurotropic virus affecting the vagal nucleus, number three, degeneration of nitric oxide secreting inhibitory neurons, number four, loss of receptive relaxation, number five is a complete degeneration of myenteric plexus and vagal efferents. There are two phases of achalasia cardia. One is the early phase and one is the late phase. In the early phase, there will be vigorous achalasia and chest pain, simultaneous peristaltic contractions. In the later phase, there will be dilatation of the esophagus with retention of solid and liquids. There will be dysphagia and regurgitation. And lastly, liquids and solids equally difficult to swallow. The investigating tools are: number one is definitely an upper GI endoscopy to rule out the mechanical obstruction. Number two, we can go for a barium swallow, shows a bird's beak abnormality. Then lastly, we have the esophageal manometry. This esophageal manometry is considered to be the key diagnostic test in case of achalasia. What are the complications of achalasia? It includes nocturnal aspiration, bronchiectasis, and lung abscess. Carcinoma develops around approximately 3% of cases, and these are basically a squamous cell carcinoma. Now, what are the treatment options we have for achalasia cardia? Number one, the conservative management by medical treatments. Then we have balloon dilatation. Then we have Hiller's cardiomyotomy, a 7 centimeter single myotomy at the gastroesophageal junction is done. And lastly, we have injection of botulinum toxin. This is in short about achalasia cardia. Thank you.